Let's look at the first question for today. Which of the following is not correct for multiple sclerosis? And your options are: primary progressive multiple sclerosis is the most common type of multiple sclerosis. Vitamin D deficiency plays a role in idiopathogenesis. Sensory symptoms are more common than optic neuritis, and scanning speech is seen. So, which of the following is not true regarding multiple sclerosis? Now, so for anyone who's tuning in for the first time, I'm Dr. Abhishek, your mentor at Medico Apps, and this is Medico Apps MCQ Live. Today is the 12th session. So in these sessions, basically, we try to take a few MCQs on high-yield topic and we discuss it. And the inspiration to do these sessions are essentially, getting feedback from so many students that, sir, whatever you teach as MCQ stays in our mind, and especially on the high yield topic. So this is you know uh, effort towards that all the high yield topics, all the previous year MCQ I'm able to cover in these YouTube sessions. So today is 12th session. Every day, 3 or 4 times in a week, I'll take these sessions in the evening, 4:30, 5 o'clock, whenever, somewhere around that time. So this is the 12th session. If you have missed any one of these earlier sessions, please make sure that you go back and see those sessions. Now, if you are new to this channel, please do subscribe to our channel so that whenever I go live, you get the notification. Also, if you like this video, you can give a like, comment, and share. This is our question: which of the following is not correct for multiple sclerosis? So, anyone who wants to answer can put their answer in the comment. All of you know that there is something called as live chat. So, because this is a live session, so you can actually put your comments into the live session, live chat. So let's look at this question, and the first option is primary progressive multiple sclerosis is the most common type of multiple sclerosis. Now, what do you have to say about this? So, what are the various types of multiple sclerosis? Anyone? So we know that multiple sclerosis, basically the symptom happens over a period of time. Okay, the symptoms actually over happen over a period of time. Now, whatever symptoms we see in multiple sclerosis, whatever symptoms we see, so there can be multiple presentations of these multiple sclerosis. So when we talk about multiple sclerosis, the first set of clinical presentation will be that the patient had a symptom, then another symptom, then another symptom, then another symptom, then another symptom, and then another symptom. So there is actually no disease-free period, and one by one, each of the symptoms keep on coming, and this is what we call as primary progressive multiple sclerosis. Another presentation could be that the patient had one symptom. So let's say he had some sensory symptoms developed, and this developed in January 2023. Then, at the end of January 2023, the symptoms completely disappeared. And then he had, you know, February and March, there were no symptoms. And suddenly, in April, again, he had, optic neuritis. So, optical symptoms. And then, after some day, again, at the end of the April, he was fine. And then he had the third symptom, maybe ataxia. Okay. In May 23, at the end of the May or June, he may have. So what we are seeing is there is what we call as relapsing remitting course, and this is called as relapsing remitting multiple sclerosis. So this is the second presentation. And the third presentation is when the patient had relapsing remitting course for a certain period of time, and then he had the progressive course. So he had the progressive first relapsing, remitting, and then a progressive course. So this is called as secondary progressive multiple sclerosis. Okay, so these are the three primary types. Primary progressive, which means right from the symptom started, another symptom, third symptom, and within 3 to 6. One is secondary progressive, which means primarily he had a relapsing remitting course, and after some time He is having a progressive course. So out of this, relapsing, remitting of, yeah, because of its modulatory function. So this is a correct state. Okay. Sensory symptoms are more common than optic neuritis. So let's look at quickly what are the clinical features of multiple sclerosis. So let's look at clinical features of multiple sclerosis. Okay. So what is the most common presenting feature? So most common presenting feature of multiple sclerosis will be your sensory symptoms. Okay, sensory symptoms. So what are the sensory symptoms I'm talking about? So sensory symptoms will be, like pin and prick, pin prick sensations will be there. Okay, what other sensory symptoms will be there? There can be paresthesias. Also, if let's say a particular plaque is formed in the spinal cord, the patient will give a particular sensory level. A very characteristic sensory symptom will be that patient will tell about pain which keeps on shifting in location and varying in intensity. What do I mean by that? Is correct because patient will say that today I have pain here, and after 3 days the pain is not here, the pain is here. Okay, and the intensity of pain is also different. So initially, this is the kind of sensory symptoms you are going to get. You are going to have paresthesias, pin and needle sensation, sensory level may be present when if there is spinal cord is involved, or multifocal, multi-intensity pain will be there. And what is most important and which has been asked in the examination is something called as Youthhoff's phenomenon. What is Youthhoff's phenomenon? What is Youthhoff's phenomenon? So all these symptoms are happening when there is an exposure to heat. For example, the patient has gone and taken a hot shower or a sauna bath, or patient has gone for a running, and after running, after taking a hot shower bath, or after being exposed, he is having all the symptom. And this is, you will not read it anywhere, but only in multiple sclerosis, that all the sensory symptoms are precipitated by exposure to heat. Okay, when the core temperature rises, then all the sensory symptom will come. So this is the most common presenting feature. Almost 37% of the patient will have sensory symptom or present with sensory symptom. The second is all the optic neuritis presentation. Okay, and very closely, almost 36% patient will have optic neuritis. And what is the most common thing they will say? That there will be a decrease in the visual acuity, which means suddenly the patient will not be able to see properly, either in one eye or both eye. You know, there will be a patient who will say that within 6 months his eyeglasses, he has to change his eyeglasses 3 or 4 times. Such kind of presentation may be there. Also, what we typically see is ophthalmic desaturation. What is ophthalmic desaturation? That when the color perception in certain area will fall down. Okay, so suppose the wall is completely green. If the patient sees that wall, all the area will be fine, but some area he will not be able to. The green color will be lighter. So this is called as ophthalmic desaturation. Very characteristically, remember that if you do a ophthalmoscopy, you will not the retina will look normal. The retina will be normal. Okay, because all the things are behind retina. Okay, so that retina will be normal. Sometimes you may have papillitis, but primarily they will not be. The patient is having so much of ocular symptoms, but the retina on ophthalmoscopy is normal. So this is again very very characteristic. Remember, and this is what you have to remember very very importantly, and I'm writing it with a different color, that uveitis is not set. So you will not have any sarcoidosis, any multiple sclerosis patient with uveitis. This is very very important. So uveitis is not present. If uveitis with optic neuritis is there, what will be the clinical condition? Can anyone write? Write in the comment. If uveitis is there along with optic neuritis, what will be the clinical condition? So remember, if uveitis plus optic neuritis is mentioned, you will start thinking in terms of sarcoidosis. You will start thinking in terms of sarcoidosis. So along with uh, optic neuritis, there are some other ocular symptoms based on what weaknesses where the plaque is formed. Suppose the plaque is formed in the longitudinal, medial longitudinal fasciculus. Okay, then what is going to happen? So in that case, what will happen is patients, whichever side it is affected, whichever medial longitudinal fasciculus is affected, on that side the adduction will not be there. Suppose this is the if this side is affected, this eye will not be able to adduct. Adduction on that side will not be there. Okay, so this is called as internuclear ophthalmoplegia. So again, another very very important ocular lesion, internuclear ophthalmoplegia, which means both the eyes, suppose the right eye is affected. So when they are looking at towards the left, both eye will look towards the left. When he is trying to look towards the right, then what will happen? This eye will look towards right, but this eye will keep seeing straight. So this is called as internuclear ophthalmoplegia, and it is primarily because of the involvement of the medial longitudinal fasciculus. Now imagine, along with the medial longitudinal fasciculus, the same side the same side there is a defect. Okay, there is a defect, and this time the defect is in the nucleus level. Okay, or nerve nucleus level. Then what is going to happen? Okay, then we will have something called as 1.5 eye syndrome, which means on this side which is affected, no movement will be there. Okay, suppose no movement will be there, and this eye only adduction will be possible, which means he can look away in that eye. That is called as, because 1.5 movements are not there, so that is called as 1.5 syndrome. So that again can be asked, 1.5 syndrome. In 1.5 syndromes, remember here only medial longitudinal fasciculus involved. Here medial longitudinal fasciculus, as well as the plaque is in the eye, in the nucleus. Okay, in the nucleus, sixth nerve nucleus, sixth nerve nucleus. So, so in one eye, whichever area that is no movement will be there, and in the contralateral side, only adduction, that is moving away, will be possible. So these are all the ocular symptoms. What are the other ocular symptoms? What are the other ocular? What are the other symptoms? So there can also be associated facial nerve palsy. Okay? Facial nerve palsy. They can also be associated facial nerve palsy. And this facial nerve palsy, just 1 minute. Yeah, this facial nerve palsy, what we are talking about. Okay, so so the next symptom. So what we have seen the sensory symptoms. We have seen the optic neuritis. We have seen about internuclear ophthalmoplegia. We have seen 1.5 syndrome. Okay, then there will also be facial nerve palsy. Okay, facial nerve palsy. So seventh nerve and here the characteristic feature about this facial nerve palsy is that there will not be any loss of taste sensation. Taste sensation will be preserved. So this differentiates it with Bell's palsy. Okay, so facial nerve palsy will be there, but there will not be any loss of taste sensation. And 1.5 syndrome and facial nerve, if both these are involved, then this is called as 8.5 syndrome. So 1.5 syndrome I have told you. Facial nerve is seventh nerve, so 7 plus 1, 8.5. So this is all. Also, if you take a history, patient will talk about weakness or pain in legs, muscles, and back. And what is this pain, weakness? Basically, that because of the this is kind of an upper motor neuron lesion, so there will be a lot of spasticity and this spasticity is complained by patient as your weakness. Okay, then you can also have certain symptoms. You can also have ataxia in these patients. Ataxia in these patients. You can also have vertigo, deafness, and all the other nerves being involved. And remember, you will also see bladder and bowel involvement in multiple sclerosis patients. So these are the various clinical features, and based on that, sensory symptoms. Yeah, this is also correct. And scanning speed. What is scanning speed? So the patient will be literally speaking like if you ask him, "What is your name?" So he will say, "My name is Abhishek." So he is like searching for words. Slowly he will be speaking. Okay, so that is called a scanning speech. Again, this is seen in multiple sclerosis. So having understood all this, so the correct answer here is primary progressive multiple sclerosis is more common. No, it is the least common, and the worst prognosis multiple sclerosis. So this with this, let me talk about our daily updates. If you are new to Medico apps, you know that we keep sending daily updates on high yield topics, live session of these notifications. We create a lot of concept visual cards and send it to you over WhatsApp. We send short videos, quizzes, and a lot of free PDFs. And you can join and get all of these by directly joining to me on WhatsApp. You go to this URL medicoapps.org/groups, and what you will find there is a first year group, second year group, final year group, intern group. You can join that, and based on whatever group you have joined, you will start getting notifications. So if you are a first year student and if you join a first year group, you will keep getting notifications only on anatomy, physiology, and biochemistry. And remember, these are all admin post only, which means no good morning, no good evening messages. You cannot put in a lot of it. Only high quality updates from. Let's look at this question. This is the second question. Which of the following has no role in management of Guillain-Barré syndrome? And your options are steroids, plasmapheresis, immunoglobulins, and ventilatory support. So if anyone is can you put the correct answer in the comment? Can you put the correct answer in the. So we know Guillain-Barré syndrome. Again, it's an type 4 hypersensitivity reaction. Okay, and hence the. So we know that IV immunoglobulin is the treatment of choice for Guillain-Barré syndrome. Okay, if this is not possible or if there is no improvement with those, the second is plasmapheresis. Okay, because most of this patient will end up in diaphragmatic paralysis for a long period of time. Ventilatory support, tracheostomy again forms very integral part in management of Guillain-Barré syndrome. However, steroids have been shown to have no benefit or no role in management of Guillain-Barré syndrome. And this is where the examiner is trying to trick you, because you will think that that it's an hypersensitivity reaction. You will think in terms of steroid, but the steroid has no role in management of Guillain-Barré syndrome. Let's look at the next question. Complex 3 in electron transport chain is inhibited by. Complex 3 in electron transport chain. Now, inhibitors of electron transport chain is one of the most commonly asked questions. So let's enumerate that. So we know that when an electron flows, so there are two pathways it can take. So one pathway is when the electron travel from complex 1 to complex 2. Okay, and who is the carrier here? Cytochrome Q. Okay, again from complex 2 to complex 3. Again, who is the carrier here? Cytochrome Q. From complex 3 to complex 4, who is the carrier here? Cytochrome C. Okay, and from closely linked will be your ATP synthase. Okay. Now we have to know the inhibitors of each of these electron transports. This is a very critical question which they will keep you asking. So let's try and learn this so that we know it forever. So when we talk about complex 1 inhibitor, okay, complex 1 inhibitors are here cysteine A, emma, barbitol, and rotenol. So what is common in that? You see, rotenone has ONE1, quercetin has A, and amobarbital or phenobarbital ONE1. So all these are complex 1 inhibitor. Okay, let's talk about complex 2 inhibitor. So in complex 2, we know that succinate gives it to complex 2. So what is the who is the inhibitor of transfer from succinate to complex 2? Remember, malonate. Malonate is a competitive inhibitor. It will inhibit the transmitter of transmission from succinate to complex 2. What are the complex 2 inhibitors? What are the complex 2 inhibitors per se? So it will be carboxyl and TTFA. So you can see double T and carboxyl has B. What are the complex 3 inhibitors? What are the complex 3 inhibitors? Let's talk about complex 3 inhibitors. So there are two complex 3 inhibitors: British anti-leukocyte, 3-letter word, and antimycin A. Antimycin A. So these three are 3 letters word, complex 3 inhibitors. Let's look at what are the complex 4 inhibitors. So complex 4 inhibitors, we have got CYANID, cyanide, okay, carbon monoxide, hydrogen sulfide, and sodium azide. So if you see, all of these have IDE. Cyanide IDE, carbon monoxide IDE, hydrogen sulfide IDE, sodium azide IDE. So all these are complex 4 inhibitors. Let's talk about ATP synthesis. There are two mechanisms by which ATP synthesis is stopped. First is, inhibition of entry of hydrogen ions. This is done by oligomycin, and the second is, you know uh, there is an inhibitor which inhibits the ADP ATP transporter. All Once the ATP is formed, it has to be transported out of the mitochondria, and ADP has to be transported inside the mitochondria, and this transporter is inhibited by attracto attractoside. So these are the important inhibitors of electron transport chain. You have to know it because every year they will put one question on this. So this is all what I have tried to hear. Let's answer this question on inheritance. So what kind of inheritance is this? What kind of inheritance is this? So let's look at mitochondrial. So mitochondrial is very easy because in mitochondrial, mother will give to all children. So we have to find a affected mother and see if she is transmitting it to all the children. So here is an affected mother, but all the children are not affected. So we can easily rule out mitochondrial. Y linked, only male has to be there. So male, female both are there. So we can easily remove Y linked. X linked recessive and X linked dominant. So X-linked dominant is relatively easy. You find an affected father and see if all the daughters are affected. Okay, for X-linked dominant, very easy. Find an affected father and see if all the daughters are affected. If all the daughters are affected, then it's an X-linked dominant. Okay, so let's look at this. So he is an affected father, daughter is affected, daughter is affected, daughter is affected, son is not affected. So this is X-linked dominant. Can we find another affected father? Yes, here is an affected father, both the daughters are affected. Here is affected father, both the daughters are affected. So this is an X-linked dominant. And anyways, when we talk about X-linked recessive, remember, male will be much more affected than female. Okay. Here, if you have to count male and female, so one, two, three, four. So male is 4 and female 1, 2, 3, 4, 5, 6, 7, 8, 9. So female is 9. Whereas X-linked recessive inheritance, remember that male is more commonly affected than female. This is a case of X-linked dominant inheritance. The last question for today, it's an ABG analysis. Various students have kept on telling me, sir, please, keep discussing ABG questions because that is a difficult area for them. Let's discuss this. So ABG, even if I don't read it, these are the easiest questions. So first, always look at the pH. So we know the normal pH is 7.35 to 7.45. Anything below this is acidosis. Anything more than this is alkalosis. Any doubt in this? So 7.22. So we are knowing that it is an acidosis. Acidosis or alkalosis. First, always use the respiratory cause. So suppose we presume that it is a respiratory acidosis. How can we confirm? We will look at the PCO2. Because in respiratory acidosis, what is happening? The CO2, carbon retention is happening. And if carbon retention is happening, the PCO2 has to increase. So what is the normal PCO2? Okay. So let's look at here. The PCO2 is actually decreased. Okay. PCO2 is very, very low. So it cannot be a respiratory cause. So it will be metabolic. Because we have seen it will be metabolic. It will be metabolic income. Normal PCO2 is 35 to 45. So here it is 21. So PCO2 is here. Now, so we know that this is a metabolic acidosis case. So the correct answer will be metabolic acidosis. Now, if we have to comment that is the compensation started or not? So if it is metabolic acidosis, what will be the compensatory mechanism? It will be respiratory alkalosis. What does respiratory alkalosis means? That the CO2 has to be washed out. Okay, so CO2 has to decrease. So this is CO2 we can see is decreasing. So yes, the compensation has started. But is it fully compensated or partially compensated? Remember, if it is fully compensated, the pH will come into the normal range. So pH has still not come into the normal range. Can you see? The pH here is still 7.22. It's not 7.35. So if it was pH was coming towards the normal, then we could have said it is fully compensated. But because pH is still not coming to the normal range, then we can say that it is partially compensated. So correct answer will be partially compensated metabolic and acidosis. So hope you are correct. So the correct answer will be metabolic acidosis. So this brings us to the end of today's session. And before I end, let me talk about something which we constantly feel all our students suffering. And we know that revision is the biggest challenge for all our students. So is revision also a big challenge for you? And why revision is so much a big challenge? Because when we talk about NEET PG, there are lots of information. Revision also is very, very boring, and even no matter how much you revise, you keep forgetting. And for that, we have something called as concept cards. Concept cards present high yield information in an image and a flowchart based manner, and which helps you in active learning. If you want to know more about it, go to our Instagram page or download VideoApp's concept card app, and you will get to know. One last thing, again, a gentle reminder to join our daily WhatsApp group. The link will be there in our description also. And please do like, comment, and share this video, uh, all of you. So to the next session of these of this will be the next session will be, I think, let me just show you. So these are the sessions which I've taken. So today is 23rd May. So tomorrow again there will be session at again 4:30. Hope to see you then. And these live sessions are just sometimes you keep trying to study, and you have tried the entire day but still you are not able to study. But these live sessions, even if you attend, not only you will learn more about some very high yield topics, but you will feel very motivated, and maybe for the entire day you have not been studying, but after this session you will feel like studying. So hope to see you tomorrow for the session number 13 at 4:30 p.m. for another MCQ live session. Thank you so much, guys. If you have any doubt in today's session, or if you want to me to include questions of a specific topic, please put in the comment, and I'll definitely read it. I'll reply it and try to take your suggestions and feedback.